Good evening, everyone. This talk was supposed to be for the beginners in cornea or juniors, but it looks like I'm the junior most here. So I feel privileged to be a part of this historic AIOC midterm, and I thank the AIOS Scientific Committee for this opportunity. So the next 7 minutes, I will introduce you all to some corneas who came to me with a mask on, and to an extent was successful in fooling me until eventually I unmasked and saw the real face. So I will introduce you all to them, so next time they come to you, you know the real face already. More than what meets the eye. After all, no one can wear a mask for very long. So this first cornea who was referred to me for further management of peripheral ulcerative keratitis. Yes, it looks like PUK because it's peripheral, circumferential, and patient did give history of recurrence. But there was something unusual about it. The extreme periphery near the limbus, where there should be thinning, was spared. In fact, there was thickening, there was limbitis. The nasal area was normal, the other eye there was no evidence of thinning, but still it erred more on the side of PUK, so I started the patient on topical steroids, cycloplegic and lubricants. I was happy on day 4 when the patient was symptomatically better, the congestion had significantly reduced, the edges were now sloping, epithelial defect appeared to be healing, but the autoimmune workup came negative. 2 weeks follow-up, I was on cloud 9 because the original lesion had almost healed, the epithelium defect had healed, but inferiorly there was a circumferential extension and there were keratic precipitates. I referred the patient to immunologist considering that it was worsening of PUK, and then the patient comes back to me with this picture on immunosuppressants. Impending perforation, significant worsening. I planned a glue BCL and microbiological workup, but as a routine I stained the cornea. And there was a large geographical ulcer staring at my face. So this was a case of HSV keratitis. When managed with antivirals, I deferred the glue BCL and the patient did extremely well, with a lot of astigmatism though. The second case, which came with a mass lesion on the cornea, I didn't know what it was. I thought it could be a keloid. OSSN was one of the DD, but unusual because it was a very uniform, smooth surface. I thought of exploring. I planned a superficial keratectomy, but when I took the patient on table and I just held this lesion in the forceps, it came off the cornea just like a sticker on, or as easy as peeling a BCL. So this was a case of chronic pseudophakic bullous keratopathy, and this was epithelial hypertrophy which was confirmed on histopathology. We could also see some old enterostomal puncture marks on the cornea. Patient was totally asymptomatic for all these years because this mass lesion was acting like a bandage. I did a DSEC and he's doing fine. This third case was referred to me for therapeutic keratoplasty. The referring surgeon thought it's a limbus to limbus corneal infiltrate. So this white thing it's not into the cornea, it is on the cornea if you have a look at it. Within few minutes, this is how the cornea looked. All that I had to do was patiently peel the plaque off. So this is a case of fungal keratitis with a dense plaque, which came KOH positive. Patient did very well on antifungals and there was no need of therapeutic keratoplasty. This fourth case was referred to me with a bandage contact lens as a case of worsening superficial keratic infiltrates. I saw the patient was happy, he was symptomatically better, already on antibiotic lubricants. I said, let's just observe. When the patient came back to me later, this was the picture. It looked different, some weird pattern, but these infiltrates were more superficial than it should have been. And on careful observation, they appeared to be moving with each blink and moving with the BCL. All that I did was remove the BCL and they were all gone. Few were sticking to the epithelium. So basically they were the deposits under the BCL that gave an impression of superficial corneal infiltrates. And this last and most interesting case is a 30-year-old young man who came after 2 months of injury with a sugar cane. He denied any history of eye surgery in the past. So it looked like a lamellar corneal tear which had healed with it was stain negative, the epithelium had grown over it, but there was this trapped lesions which I thought it's either a foreign body or an infiltrate or some trapped debris. On slit lamp again it looked something unusual. If it was just a lamellar flap, I couldn't figure out why there was so much of interface scarring, and it looked thicker, but it didn't look like edema. I wanted to start on steroids, so plan was to open up the flap, wash it, and start him on steroids. So just as I started and I wanted to access those foreign bodies, I couldn't reach them. There was something stopping me. I was struggling to reach till them. This was under topical anesthesia, and the patient suddenly moved his eye down. Yeah. And I thought I have worsened this because there was a significant extension of the thing, but it is too uniform circumferential. Does it look like a LASIK flap? Then I asked the patient, have you undergone an eye surgery before? He says no. I specifically asked, have you undergone a laser procedure before? He says yes, at the age of 18, because he wanted to enter army, and so he tried to get rid of his glasses. So the debris I was talking about was epithelium, and the epithelium had grown all over, on the stroma, under the flap. I tried all the means to get rid of it, scraped it, hand picked it, and then finally I left it to mitomycin C to take care of the remnant cells so that there will not be any epithelial ingrowth in the future. Okay, I can forward this video. So post-operatively he did fine. So things are not always what they seem. The first appearance deceives many. The intelligence, rather in our field I would say it is the experience of a few, perceives what has been carefully hidden. So don't get fooled. Fluorescent is our best friend. Always stay in every case, even if you think you know the diagnosis and you know what's happening. Trust your instinct. When you feel something is unusual, keep an eye on that eye, document with clinical photographs, and ask the experienced few. Because, and thanks to WhatsApp, that seniors and experienced people who must have seen such cases which is new to us, they can spot on say that, okay, this is this and this is that. So they are very nice and accessible. So don't hesitate to ask your seniors or share your cases and ask what it is. That will save a lot of time and will do good for the patient. Thank you for your patient listening.
Excellent cases, Asmita, really amazing, excellent cases. And you've shown that it can always be sometimes simple and often